Hello and welcome to this webinar hosted jointly by the NHS Confederation Mental Health Network and the International Initiative for Mental Health Leadership. My name is Steve Appleton and I'm the Chief Exec of the International Initiative for Mental Health Leadership, or IMHL for short. And I'm also pleased to be joined today by Sean Duggan, who's the Chief Executive of the Mental Health Network. The Mental Health Network is part of the NHS Confederation and it is the voice of NHS-funded mental health and learning disability service providers and commissioners in England. It's a membership organisation that brings together, supports and speaks for the whole healthcare system in England, Wales and Northern Ireland. The International Initiative for Mental Health Leadership is a unique collaboration that focuses on improving mental health and addiction services and leadership within them. It's a collaboration of 10 members: Australia, England, Canada, the Netherlands, New Zealand, the Republic of Ireland, Northern Ireland, Scotland, the United States and Sweden. And we enable and facilitate systems for international innovation, sharing of knowledge, networking and problem solving across many countries and different agencies. Our overall aim is to provide better outcomes for people who use mental health and addiction services and their families. It's really wonderful to have so many people joining this event from around the world. And I think we have people joining us from the United States, from Canada, Bermuda, Malaysia, Australia, New Zealand, the Netherlands, and many, many more. Today marks the first of what will be a joint annual publication between the Mental Health Network and IMHL. This year, we've focused on mental health responses to COVID. One of the effects of the pandemic has been an increased desire to collaborate internationally and for leaders in countries to share knowledge and to learn from one another. That's what IMHL and the Mental Health Network are really all about. Before I say a little bit about the rest of the process for today's session, I think Sean is with us, and I wonder, Sean, if you just wanted to say a little bit more about the Mental Health Network and the partnership between the network and IMHL.
Yes, thank you very much. I'm very proud to be working with the Institute, the International Institute, and this is what a fantastic event this is. All the countries that you mentioned there, Steve, is very impressive, and having over 70 people, no, nearly 80 people, it really is great. And it says, doesn't it, that what we all know, that at any time we need to learn from other places. We need to keep the innovation going, step back and reflect on the way we do things and change based on evidence. And we do that, we need to do that outside our regions, outside our place of work, and certainly we need to do it internationally. I don't think we do enough of it. So really pleased. I'm not going to take any more time up because we've got some wonderful speakers and it would be great to have a little bit of time for questions. Thank you very much, Dave.
Thank you, Sean. And I should just also say we're delighted to work with the network, and Sean and his team have been a fantastic support to us over a number of years. But in pulling together this collaboration to develop a publication, which you'll find on the NHS Confederation Mental Health Network website, I think now actually, and it will be on our website very shortly too. We're delighted to work together. Today is really about learning from one another, and I'm absolutely delighted that we've got some fantastic speakers who are going to share with you their experience of innovation in their own services from across the world as they have responded to the impact of the COVID-19 pandemic. I think we're all well aware of the impacts on us, on everybody from a physical health point of view. The mental health impacts of this pandemic have been significant worldwide. And I think what we're going to hear about today is innovation and how people have responded differently and in innovative ways to tackle the impact on mental health of the pandemic. And these are lessons that we can all learn from and will take forward, both as the pandemic hopefully begins to subside, to think about how we do things differently and reimagine the ways in which we work together. And as I said earlier on, the whole purpose is about sharing knowledge and information. So I encourage you to connect with one another in the chat, and hopefully you'll begin to develop some relationships which you might take forward beyond today's session. There'll be an opportunity at the end to pose some questions to our speakers. We'll try and leave around about 10 or 15 minutes for that. If you have questions, please do post them in the chat, or when we get to the Q&A session, please just raise your hand and we'll attempt to spot the hands. I can't see everybody that's on the call, but we'll do our best. So I think in order to make sure that we try and keep to time, I will move us straight into presentations. I'm very pleased to welcome Dr. Maria Gagan, who is a consultant counselling psychologist and the service lead for the Here For You service, which was launched in January 2021. It's a national health service which provides psychological support for NHS and social care staff across Surrey and North East Hampshire, which, for those of you who are not familiar, are areas in the southeast of England. Maria has over 20 years experience of working within adult mental health services, most of that time within the Surrey and Borders National Health Service Trust, and she has a particular clinical interest in trauma, as well as how organisational culture impacts staff well-being. She's also been joined in this work by Professor Helen Rostill, the Deputy Chief Executive and Executive Director of Therapies at Surrey and Borders Partnership NHS Foundation Trust. I think Helen is going to join later on, and so I'm going to hand over to Maria to make her presentation.
Thank you very much, Steve, for that introduction. And I'm absolutely delighted to be here today at this launch event and to share with you some of the work that we have been doing. So I'm hoping that you can see my slides okay. Brilliant, thank you. So I'm Maria Gagan. My colleague Helen Rostill is also on the call with me today. So I wanted to talk to you about the work that we have been doing in our service Here For You, which was launched pretty much a year ago now. So I wanted to just start by giving a little bit of background to our service. So we are a staff mental health and wellbeing hub, and we are one of 40 such hubs across England. And we were established by NHS England in response to the pandemic and a recognition really of the unprecedented level of pressure that our NHS and social care staff were under. So there are 40 of us in England. We have four main functions really. Our first function really is to provide information, resources and support to enhance the wellbeing and develop resilience amongst our staff, but with a particular focus on prevention. Also to have outreach to vulnerable staff groups that may find, for a variety of different reasons, it's that bit harder to access support. To provide easy access to support for all staff who are needing and wanting this. And I'll be talking today about the sort of diverse range of offers that we have developed within our hub to increase our reach and to make access as easy as possible for staff. And finally, to provide a pathway to mental health support for those staff that need it. And we really hope through the work that we are doing and the delivery of the particular types of interventions that we offer to actually have an impact on the culture across our local health and care system. So within our hub, we provide confidential individual support to staff. But in addition to that, we've also tried to widen our offer by delivering other interventions. We've done this to try and increase our reach to as many staff as possible and to meet our objectives around prevention and outreach. So one of those areas is the live workshops that we offer. We believe that our workshops are an easy and accessible way for staff to seek information and support on issues which they may feel less able to access if they were to come forward individually. And we do find as well that for a number of staff who attend our workshops, it sort of raises particular issues for them or a recognition that maybe they need further support, and they will then come on to contact us for individual support. So you can see here that the workshops that we offer cover a range of areas, and these are areas where staff have been impacted as a result of the pandemic. We continually review our workshops, adding to these, and we try to be as responsive as we can to the needs of our local staff. So one example is that through discussions with our colleagues who have been working in critical care during the pandemic, we became aware of the prevalence of what is called moral injury amongst many of our critical care staff. So moral injury is really when someone can experience profound psychological distress when they witness or they partake in something that seems to sort of go against their moral code, and they can be left struggling maybe with feelings of guilt and shame around that. So we've developed a workshop on moral distress in response to that. Our most popular workshops, maybe not that surprisingly, are ones on stress and burnout. We find that is very prevalent amongst our staff, but also the bespoke package that we offer for our managers and leaders. We know that for those in a management and leadership role, it has been particularly difficult trying to lead services and manage their staff during the pandemic. So our service made a deliberate decision to really also focus on teams within our offer, and we've done that for a number of reasons. So we know that there is considerable evidence to show the importance of effective team working on a number of factors, including patient care. Organisations like the King's Fund have done a lot of work on looking at team functioning and seeing how teams have been impacted during the pandemic. And we know that working in a well-structured team is a predictor of patient mortality, also staff turnover and staff absenteeism. We know as well that teams that work well make fewer errors and incidents at work. And thinking of the pandemic, many of our teams have been reconfigured, staff are working differently, teams function differently, staff have been redeployed, many teams are working remotely as well. So we felt it really important to think about how can we nurture the well-being of our teams and the impact that that may have on important areas, including patient delivery. Another reason that we've decided to focus on teams is because we have limited resources, and working with teams can really increase the reach of staff that we have contact with. We know as well that if we work with teams, we can influence the team as a whole, but also the individuals that make up that team. And in addition to that, there's potential to influence the organisation that the teams sit in, and also the wider system. So in that way, we feel that there's potential there to have an impact on the culture of an organisation, and thinking particularly around making it okay for staff to speak up and talk about their well-being, and encouraging organisations to respond to this in a compassionate way. We believe as well that this can reduce the stigma that staff may feel, and there is still stigma around staff coming forward and seeking help. And by working in this way, we can encourage more staff to come forward. And finally, we know that when we work with teams, that the well-being of the team affects the well-being and mental health of all the individuals within that team. So the staff that we've seen over the last 12 months have sought support from us for a number of different reasons, but there are some sort of key themes that have emerged that I've highlighted on the slide here. Probably the one that sort of comes through from most of the people that we see is exhaustion and trying to manage increased work pressures. So the chart here highlights the breakdown in terms of all the staff that we have seen during the 12 months that we have been operational. So you'll see that most of the staff, or 44% of the staff that we have seen, we've had contact with through our work with teams. So that equates to over 1,000 staff, covering over 64 teams, and we've worked with a very broad range of teams covering GP practices, care homes. We've worked with catering teams, research teams, and we've done a lot of work with our social care colleagues who are working with young people. Our live workshops, as you will see, are also very popular. We've seen over 900 staff that have come through from our live workshops. So in terms of our future plans, we will continue with our focus on teams and our live workshops, and also actively encouraging all staff who feel they need support to come forward. We're also wanting to further develop our train-the-trainer model because we believe that this is an effective way to cascade training and information, particularly when resources are limited. And also that teams can often respond well to training that's delivered by someone within their own service. In terms of a clinical focus, we really want to start looking more at long COVID. We know that there's a lot of emerging evidence of the considerable impact that long COVID is having on people in terms of their physical and mental well-being. And we know from research that healthcare staff are the most impacted in terms of staff groups with long COVID. And there was a report out this week actually that showed that there are 2 million work days have been lost in the NHS through staff with long COVID. So we feel this is an area we really need to be looking at. And finally, I just wanted to end my presentation by talking a little bit about the impact, highlighting the impact of our work. And that can be seen in part from the feedback that we have had from the staff that we have been seeing, but also the impact that we're having on the wider system. And one way that we are sort of thinking about this is the increasing number of consultations that we are having with leaders and organisations locally on a range of issues around the mental health of their staff. So, for example, at the moment, I'm working with one of our acute trusts on helping them develop a protocol for their managers on best practice to support staff who are expressing suicidal thoughts. We're also leading on work across our local health and care system on bringing about changes in terms of how occupational health organisations work and bringing them to work more closely together. And we're hoping through all of this work that we're doing that we can really change how organisations respond to the needs and the well-being of their staff. So thank you for that.
Thank you, Maria. That was really, really fascinating. And from what I see in the chat, a lot of people saying this is really very much needed. And I think you picked up on some very important themes, which I'm sure colleagues will want to explore and reflect upon. The impact of moral injury. I think it's a subject that's really come to the fore as a consequence of the pandemic. And certainly colleagues in our network in IMHL have discussed that in some depth. I think the importance of teams and the resilience of teams and working together you highlighted. More importantly, the impact of trauma at work and how that's responded to by an employer as well as by colleagues, family and friends. And I was particularly interested as you began to talk a little bit about the work you're doing with other healthcare organisations, particularly those that aren't specifically delivering mental health services. So helping them to think about the mental health impact of the pandemic on them, the work that they do. So really fantastic to hear about. And I'm sure that people will have questions when we get to the Q&A session, but thank you so much for that really, really excellent presentation. I will move us on to our next presentation. It is from Dr. Anu Bhokti, who is a senior lecturer at the Department of Occupational Therapy in the School of Primary and Allied Healthcare at Monash University. Anu is also an adjunct senior lecturer at La Trobe University in Australia. She is with us on the call, but as you may have noticed if you've been monitoring the chat, it's 2 a.m. In Australia, where Anu is at the moment. So we thank her for either staying up late or getting up incredibly early. But in order to help out Anu a little bit, we asked her to pre-record a video. So I'm going to ask Sally to play the video for us, and Anu will be available to take questions in the Q&A at the end. And just to say that this is a video which outlines the key benefits of online supported decision-making for families with disabilities.
Hi, this is Anu Bopti, and I'm calling in from Australia.
Hi, this is Anik Jensen, reporting from New Zealand.
So today we're going to talk to you about supported decision-making. This case study addresses supported decision-making for families raising young children with disabilities and developmental delays. It describes how an existing face-to-face strength-based planning tool was expanded for online reach during the pandemic. This approach is rooted in positive psychology and supports families to achieve their child, family, and personal goals through a novel type of partnership with professionals.
Programs for disability care often rely on reactive, deficit-oriented, expert-provided services, and more tools for parent participatory practices are needed. Pictability is a strength-based, fun goal-setting tool putting parents of children with special needs in control of the goal-setting process. Rooted in positive psychology and gamification, this evidence-based tool empowers parents to formulate and achieve goals for themselves, their child, and their families. They are in the driver's seat to optimize outcome for families and children. Co-designed with families, piloted with over 1,000 families globally, hundreds of professionals were trained in Australia, New Zealand, Finland, and Canada, and presented at the United Nations. With COVID-19 pandemic, face-to-face supported decision-making with pictability and training workshops for facilitation had to halt.
The main barriers to implementation was firstly, how do you still keep the fun element in an online version? And how do we engage service users during the pandemic? And lastly, how do we get funding for our project? What I really like about this supported decision-making process is the information that it provides to professionals like myself. In less than an hour, the family vision board details two important elements. Firstly, the goals that the family commits to start working on their own. They are the ones that are circled in blue. And secondly, the goals which we collaborate to work together. So it's circled in green on the left. I like this because it provides professionals a new and powerful way to formulate goals whilst building unprecedented rapport with families. With the help of our existing networks of parent alumni and a group of tertiary occupational therapy students, and with the help of in technology experts, which we really needed, we formed a subgroup committee to brainstorm and plan this online version of Pictability. Trained peer workers along with OT students co-designed and facilitated the online programs. A pilot of the ePictability version with a group of 10 families and professionals established that its outcomes compared to our benchmark. Participants were confident that we could uphold our impact, that between 85 to 96% of families who engaged with the online program achieved their child, family, and personal goals. The ePictability tool supported parents in ways comparable to the face-to-face process to formulate goals for themselves and their child and family. In order to ensure that we can sustain and grow this program, we will continue to do the research and build evidence on the use of this online version. We will create new training platforms for facilitators, and we will continue to look for funding, and we'll continue to add specialized technological capabilities.
And now it's time to show you what users actually do online. They start by watching a video clip about the tool and first identify their child's strengths so that these strengths can authentically underpin the process. They creatively brainstorm to select cards that represent their goals, as I'm doing now. And the platform then presents them with only the cards that they have selected so they can start writing long-term goals for their child, their family, and themselves, and place their goals on their vision board. As Anu said, child goals are divided into two, those focusing on the families collaborating with professionals and those focusing on the family agency goals, because they choose what goals they can start with right away. Inspiring parents to make an immediate start on some goals is ideal when parents go on waiting lists to see professionals. Finally, time for action. Users choose 3 long-term goals to start with and plan their first steps, or shorter goals for each one of them. Research is clear. Families who experience initial success in achieving their goals are stronger in their commitment to actively participate in the process. Families are emailed these child strength summaries, vision board, and action board. Some hang them on their fridge right away. Professional says that they get all the information they need in less than an hour to start the administrative process, because this tool is both efficient and effective. So much so that we've started developing versions of the Pictability supported decision-making tools for all age groups. Thank you for listening to our presentation.
Well, it's absolutely fascinating, and I think that Annie will. I'm sure you'll get some questions at the end. I mean, I think the reflections I have are about adaptability. You know, it's forced you and your team to move this service online. Now, many services have moved online around the world, but that's not as straightforward as it may seem. And you've clearly made a success of that. I think that sense of being able to adapt and change rapidly, make that pivot, as has often been said in recent months, is a really important skill that all of us have got to learn and develop. And I think I was particularly struck by the very high levels of goal achievement that were reported despite the move to online. So I think there are a number of lessons for us to learn, and I look forward to hearing a bit more about it later on in the Q&A. We'll move on to our third speaker. I'm delighted to welcome Yanxin Zhang, who is an assistant professor at the Department of Psychological and Quantitative Foundations at the University of Iowa. And if he's still got the fantastic background up that he had when he joined the call earlier on, you'll be impressed, because the University of Iowa seems to have a fabulous campus. Really delighted that Yanxin's joining us. He's going to talk about online peer support models for families who care for children with disability. And I should also say that his research focuses on the intersection of prevention, intervention, and implementation sciences for youth mental health and multiculturalism. And he also studies behavioral statistics, cross-cultural adaptation of evidence-based practices, and psychological technology innovation. So I think we're going to learn a lot from Yanxin. So I'll hand directly over to you, Yanxin, for your presentation, and thank you for joining us.
Thank you so much, Steve. I'm flattered by your introduction. And hello, everyone. Today, I'm going to introduce a multi-year, multi-continent project to use positive psychological principles to support the well-being of parents raising children with disabilities during the pandemic times. And we call it Now and Next program. Before we dive into the details, I want to acknowledge our research team, who are wonderful and from 3 continents around the world. I have to say, they are the ones who did the hard work behind the scene. I'm just a methodologist who stand on the shoulder of the giants in my team. We got Mogi, Silvana, Anik, Richu, and Peggy, and many others. For the sake of time, I will go hyperspeed in this presentation, and we'll have to regretfully skip some details. But no worries, if you want to learn more, you can connect with us right now at the link in handle. And feel free to send us any questions anytime for resources or join us. So the agenda. I know I have 10 minutes, so let's see if I can go hyperspeed and make it through all the content before I got kicked out. The first is the problem we are facing now. The pandemic has led to a wide range of system-wide impacts on families, especially those raising children with disabilities. For example, they receive less support than pre-pandemic times. Many of them have to deal with constant feelings of social and emotional isolation. Many of them report difficulty with adjustment to the changed routines, and they show declined participation rate in support programs and increased stress across different settings. The more importantly is they there are severe disparities for families from minoritized background worldwide. So the big question we have now is how we can use an equity-focused approach to reach out to and support these families effectively during the pandemic year. So our proposed innovation is to offer these families reliable peer support networks amidst the uncertainty of the pandemic. To overcome the impact of the pandemic, we extend from established face-to-face peer support programs to virtual setting via Zoom. What's more, families of children with disabilities are key stakeholders. They know their children, they know their life. So we include them to co-produce a program, such as decision-making, planning in their lives towards the 3 overarching goals. One is empowerment. Then it's improved social network. And last but not least, is goal attainment. So now, our next big question is, can we virtualize peer support for families suffering during the pandemic? Our active ingredients, or the special sauce of our innovation, is a virtual service provision modality. As shown here, the face-to-face format of the program of Now and Next has proven effective in prior research, but can we replicate its success in the virtual way to break through the lockdown and connect families worldwide? So to implement our innovation, we devised 2 options for our parents. One is full-course, full-length, 8-week, 100% virtual format support groups. The other is 4-week hybrid for those parents who need both virtual and real-person connections. Certainly, as applied researchers, we foresee challenges to implement those innovations in the real world. First, it's tough to reach parents when they are feeling so insecure amidst the pandemic. We address this by launching a lot of new social media campaigns to proactively reach out to parents who are looking for help online. Second, it's difficult to engage parents online during pandemic lockdowns when children are at home or they are working from home. How many of you have the experience that you are in an important meeting, Zoom meeting, and your kiddo comes by asking for something? And we address this by collaborating with our parents to design modifications of how we engage with them. Last but not least, the money talk. How we can secure funding to provide free programs to families already struggling financially. Good news is that in Australia, for example, we successfully get some funding, and later on I will introduce you to our funding that free programs actually works sometimes better than the paid ones. Now, 2 years ago, we started an international research team as introduced in our first few slides. For this project, our team aimed to answer 3 questions here. First is, how effective is this virtual Now and Next program on parents' well-being? Second, is the virtual format of the program fare out at least equivalently to the face-to-face format? Third is, what factors actually differentiate the effect of a Now and Next program? Let's see. Here's a snapshot of our overall sample. As you can see, we have fair share of fathers joining our program. A large portion of our participants are non-English speakers, so we provide a program in their community language as well. And here is a snapshot of all the countries, our participants are from. And as you can see, they're from all 6 continents. Well, we have not recruited any penguins yet from Antarctica, but that may be the plan for the future. So here is the in-depth data breakdown for our subgroups during the pandemic. As you can see, the demographics of groups during the pandemic are very similar to the general group, although the ratio are a little lower because it's all commonly seen in service participation during the pandemic. To measure the target outcomes of our parents which we want to improve through our program, we use several evidence-based assessments of their well-being, their sense of empowerment, and sense of hope. If you're interested in those measures, please reach out to us. And for the models, well, I'm a stats nerd, so this is where I get excited. We built a series of 3-level multi-level models to see how our program and implementation characteristics fare out for parent well-being. No stress to decipher these gibberish equations. I will translate it to plain English for you right now. Let's see here. Multi-level model is just a fancy way to do regression. It enables us to examine data that are naturally nested within each other. For our case, repeated measures of well-being are nested within individual parents who are nested within different groups. So here is our result. To summarize our 10-page results report to one sentence, peer support groups can indeed empower parents of children with disabilities, while group characteristics indeed moderate their effectiveness. So here is a list of group characteristics we probed. In a nutshell, language, program length, and delivery format matters most. So first of all, we found out there's no difference between the effectiveness between virtual and face-to-face programs. This is great because we want to see virtual support is as effective as face-to-face format. Then the briefer session is more effective. So, well, who doesn't want more free time? And groups delivered in community language is more effective than pure English ones. Here's what I summarized in the previous slide. I want to call your attention, please, to the last piece, our big question. Virtual support groups indeed work, at least as same as the face-to-face ones. This is consistent with telehealth literature and very meaningful funding for us during the pandemic time. Now, we want to hear about voice from our participants. As you can see, we got unanimously positive comments from our program. The participants, their feedback literally makes the day and weeks and years for our team. Our program is ever improving because we proactively engage our participants in the co-productive development process. We train parents as peer workers to co-design and run the online programs, and they are also trained to observe and collect data for program evaluation. Now, let's envision the future. As you can see, we have a lot to do in the years to come. We have multiple ambitious objectives, but the ultimate goal is to make a population-level positive impact on the well-being and success of parents raising children with disabilities around the world, because they are often the forgotten group in literature. Thank you, and if you want to learn more information, please go to the LinkedIn handle, and if you are interested in the details of our theory of change, feel free to log into the link, and I will provide it in the chat later. Thank you.
Thank you very much indeed, Yanchen. That was absolutely fascinating. I was delighted that you translated the equation, because that's not my strong point. I was very grateful for that. I think you highlighted a number of really important issues. Firstly, the importance of reliable peer networks, whether they're virtual or whether they're face-to-face. You identified some of the barriers that needed to be overcome, which really seemed to me to inform the solutions that you were coming up with. So that I thought that was really important. The sense of empowerment and hope through these networks, and the importance of peer support, and the value of service user involvement. And I'm sure colleagues will want to touch on that later. I think the most striking thing was the fact that you found no difference between online peer support and face-to-face peer support, and that actually virtual methodology gives you the opportunity to reach many more people. So there's an issue of scale, which I think many people will be interested in, particularly as you think about the sorts of areas where people are working around the world where it's much more rural, and transportation and access to face-to-face services can be particularly problematic. So really fascinating presentation, and thank you so much. On to our final presentation before we move to the Q&A. I'm delighted to introduce two colleagues from Canada, Cindy Moriarty, who's the Director General of Health Programs and Strategic Initiatives within Strategic Policy Branch at Health Canada, and Dr. Anne-Marie Churchill, who's the Executive Director of Stepped Care Solutions. And they're going to talk to us about Wellness Together Canada. That's a collaboration between Health Canada, Stepped Care Solutions, Kids Help Phone and Homewood Health, and it delivers mental health and substance use support to people across Canada. Cindy is responsible for leading Health Canada's response to mental health, which included establishing Wellness Together. She's also responsible for a number of other health system initiatives. Anne-Marie has been the Executive Director of Step Care Solutions, which is a Canadian non-profit organisation and consultancy group that aims to promote mental wellness by transforming mental health systems. And she's also a national leader in the design of innovative care models. So I think we have two fantastic experts from Canada. I'll hand over to you both now for your presentation. Cindy.
Thank you, Stephen. Good morning, good evening, good afternoon, everyone. I'd like to start by saying I'm coming to you from the unceded territory of the Algonquin people in Canada. Very pleased to be here. I'm quite keen to jump into the Q&A. I've kind of lost track of what I wanted to say because I've been listening to all the speakers before, and I think there's a lot of things happening in Canada that are going to resonate with previous experience speakers, and hopefully with you as well. I thought I would take a few minutes to speak from the government perspective in terms of what our objective was and what we were trying to do with Wellness Together. And then Anne-Marie can tell you what's really happening on the ground and from a clinical perspective. So back in the very early days of the pandemic, in March 2020, actually, we had a very small mental health team at Health Canada. And we were aware that with the pandemic, everybody was stressed out. We were stressed out, you know, like we should be doing something to provide some support to people. And also very mindful that people with mental health or substance use issues would be cut off from their supports and services because we were just going into our first lockdown. And at the same time, maybe just for context, and for those of you that are not aware, in Canada, the delivery of healthcare and health services is the responsibility of our provincial government. So it's unusual for the federal government to be in the service space, but we were also very aware of the pressure on provincial systems that they were not able to kind of respond to the needs. And so we decided that we needed to put in place a virtual care model, some sort of support for both mental health and substance use. And I can tell you with complete frankness, we were very naive. I don't know if you remember what you were thinking in March 2020, but you know, we really had no idea what was in front of us, and here we are 2 years later. So we did a very, very fast contracting process, a competition. We started very much with a 4-month contract that, you know, that we could renew. So we were really thinking of something that's short term. How can we provide some supports that are virtual? We were aware of some very innovative models that were coming out of the eastern parts of Canada, and the stepped care approach, which Anne-Marie can talk about, and peer support. And, you know, is there a way to make this virtual? And so what we ended up with was the successful bidder was the consortium that's now known as Wellness Together Canada. It was launched on April 15th, so like 1 month to the day, I think, after the first lockdown in Canada. It's free. It's free for use because the Canadian government is paying for it. It's available 24/7. It's available in a number of languages, English, French, and other languages that are used in Canada. And it has become, you know, Canadians don't like to boast, but we are very, very proud. It has really become a gem, and it's now part of the foundation of our healthcare system. So I think the benefit of having a number of organizations working together, coming with the experiences they had in providing step care and providing peer support and providing some virtual support and bringing that all together. And I think one of the things that we've learned over time is that this is a living, it's really like a living organism. It has had to pivot and had to change several times over the course of the last 2 years, as we've learned things through the pandemic and as other crises, for lack of a better word, emerged, like, you know, starting first with our essential workers, you know, working in groceries, petrol stations, healthcare workers, first responders. Then we've had some issues in Canada, such as forest fires and floods, which have been devastating for communities and for the agricultural sector. And then on from a diversity and racial point of view in Canada, there's been this uncovering of mass graves from the former residential schools where Indigenous children were sent. That has caused all sorts of trauma, and it's been very triggering. And then events like the murder of George Floyd last summer, the Black Lives Matter movement, all of these things cause a ripple effect. And all of it has necessitated for the Wellness Together partners to pivot and start thinking about what are some dedicated supports? What is the outreach that we need to do? How do we make sure that we're connecting with this with these needs? So it truly has been build it and they will come experience. We're very, very happy with the usage. Anne-Marie can speak to that a little bit more, but we're seeing the benefits of virtual care from the point of view that individuals that don't usually avail themselves of services are using Wellness Together. So higher numbers of men that we might see in other care settings, higher numbers of Indigenous people, good numbers from the LGBTQ community, and so on. And then just most recently, Wellness Together has launched a companion app called Pocket Well. And so we're looking at providing ongoing support to Wellness Together. We know that the effects of the pandemic are going to continue for some time. And as I said, this is really part of the landscape now. So I think I'll stop there, Anne-Marie, and let you tell them what's really happening.
Yeah, well, I'll just say for sure, thanks, Cindy, that you're right. It's been quite a journey over the last, we're coming up to 2 years. When we first started, we were doing transformation of systems in provinces, post-secondary organizations, using what many people already know about it, the stepped care model, and then our own model that we developed with Peter Cornish at Memorial University, a stepped care 2.0 model. It really prioritizes choice, open access, and continuous improvement processes within the system transformation. So very quickly, we pivoted to adapt this to a population level mental health approach. So rather than just be a clinical, how do we use this model to really address the needs of the population in the pandemic era? And we've made lots of mistakes along the way. I want to say that we're still improving. This will be a continual process, a living, breathing entity, as Cindy has mentioned, and we've learned so many things from it. We started out, of course, we talked about choice of the service user in particular. And the first thing we did was there was a sign up to get onto the portal, and we heard loud and clear, how is this open access and how is it providing choice? So we had to change very quickly. We brought on some behavioral scientists that helped people activate their choices. We designed a progressive sign-on where people can start to decide how much data they want collected on their behalf and stored for their use, first and foremost. They could disable cookies or use cookies so that they could track their progress and their programming over time. They could sign in or not sign on to do self-assessments or self-guided courses. So we gave choice around a very important piece around progressive sign-on, which can create barriers. So we learned that quickly. We also gave choice with how people could engage. They could do it by themselves. They could get a program navigator available, a live person 24/7, help them find their way around the portal, or they could immediately call a counselor and get counseling help. So again, there was this progressive idea, stepped care idea of how they engage with the site, what they use, and then of course their choice in the resources. So we wanted a full continuum of care, and it's this virtual approach is just such a new way to do things because we wanted the continuum of care delivered virtually. So everything from mental health promotion and literacy, which many of us were doing virtually, we could provide information. But then we also wanted the self-guided courses and the peer support for emotional support, but also for addiction support and substance use concerns. And then we wanted crisis support and we wanted individual counseling. So we actually built out our continuum using a lot of our partners and vendors that we were already using in our other systems at post-secondary and provincial. A lot of them partnered with us, came on the portal very quickly, set up their programming to offer those options so people actually had choice. And then again, the open access piece, making sure there were no wait times. So it was interesting to hear some of the feedback on that, where counselors who were available 24/7, no wait time, provided through Homewood Health, which is a large EAP service throughout the country that offer their services in French and English and then translation in many other languages. Their counselors would be waiting and people would use the number and call in. And then when they realized they were talking to a counselor, they actually asked if they could have more time because they had just thought they would have to wait. They weren't quite prepared. So that was a really interesting development to realize that when we provide open access and counseling, it's not always what people are looking for in that moment. So it really helped us think about this idea that one solution won't work for everybody, and that the idea that everyone would line up for counseling, which was an assumption we had and providers had, when we're finding about 50% of people or more are choosing self-guided and apps or roaming around the front page of the portal before they sign up or before they call a counselor. National polling showed this as well, that a lot of people wanted to do self-guided or self-managed. We had a large survey in our country on nurses, and about 50% said they wouldn't reach out for help. And when the follow-up question was, why not? They said they wanted to self-manage. So we've really bolstered that. We've bolstered our options around self-guided resources or even coached. So we have that step care approach where you can just have some information, or you can watch some videos, or you can do a longer term guided program, CBT programs, or you can just have a coach, or you can get a counselor. So there's lots of options for people to try different things, or to just immediately call a counselor or a crisis responder offered through the Kids Help phone line. And then the third piece is that continuous improvement. So we get feedback all the time. You can imagine a lot of it comes through Health Canada, or comes directly to us. And we have feedback surveys that we send out to people who register on the site. They're invited to give more in-depth interviews. We have focus groups. And through that feedback, we've been continually improving, redesigning, and more recently tailoring programs. So Cindy mentioned with Indigenous groups, we now have information and banners on the residential school crisis. We've had some really difficult environmentally related issues around the country. And those provinces or territories have partnered with us to co-design resources. So people reach out to us, can we have this on the portal or that on the portal? So we go into co-design mode, meet with them, what would be helpful. And then can really, because we do regular sprints of development and content, we can adapt really quickly, and we can add programming, we can tailor, change, upgrade, improve programming, so that we're really trying to meet the needs, fill gaps. We have great programming in our provinces and territories. Of course, it's not always 24/7, not always for minority languages. So what we're trying to do really is fill gaps and reach people where they're at in different ways, so that the needs of the population can be addressed more fully. So I'll stop there as well. Lots of metrics. We have over 2.1 million unique users at the portal. As Cindy mentioned, there's a breakdown. We seem to have more males using the portal than we would see in typical clinical services. And the most use is among the 18 to 30 age range, which is really interesting because that's also quite a vulnerable time for people, and that age group often doesn't reach out. So it's nice to see that that group is using the portal as well. So I'll stop there. Thank you so much.
Thank you both very much indeed. Absolutely fascinating. And I was fortunate enough to know a little bit about this in advance through some of my colleagues in Canada. And it's a really fantastic innovation. I'm going to try and save some time by not summing up so much at the end of this, because I know that people will want to ask some questions. And as always, we run a little bit over time. We will keep the meeting going until we sort of get to as close to just after 4 p.m. as it is here in England for me, as we possibly can. Please do put a question in the chat or raise your hand and we'll try and spot. But perhaps the first thing to ask is a question from Charlene. Any of the speakers can answer this. How did you raise the profile of wellness together, actually specifically indeed for you, Anne-Marie and Cindy, sorry. Was it attached to a universal and targeted campaign? 2.1 million users is amazing. And are you adapting the portal continuously with insights and co-production? So a question for the both of you, I think.
Continuously improving, absolutely, based on the feedback. And the awareness is key. We've reached out to a lot of our partners. We do have toolkits. We have public health agencies that reach out, and they're disseminated to them. Recently, pharmacy groups across the country have asked for resources. So there's a lot of resource sharing, not so much a media campaign, but more what we call organization to organization. And then Cindy, I'm sure you have a comment.
Well, I don't want to take up too much time, but I think it never hurts as well when we can slip remarks into the Prime Minister's speech or when the Health Minister is doing media. So we try and use those mechanisms as much as we can as well.
I don't know, actually, if you might be interested in the next question. I know Yanshin's on the screen as well, but I think there's a question about how you've approached increasing access to services for groups that might not be able to easily access online services. We know a lot about the kind of some of the inequity in relation to digital access in many countries in the world. And I just wonder what your experiences are therefore in terms of that accessibility piece.
That's been a huge consideration for us. One of the things is, of course, there's a few options. So some are web-based and app-based, but also telephone-based. So we're trying to do low tech as much as we can. The other thing that we've done is talk to a number of groups and organizations around where they can have centers or hubs for people to use the portal. And so reaching out at grassroots to enable more accessibility for people who don't have technology. Some of our houseless populations in shelters. And so really helping different organizations to know about the portal and be able to reach out to their populations to let them know that they can access through them for people who don't have technology, but then also making sure as many services as possible can be accessed through a telephone.
Really helpful. Yanshin, have you got any thoughts on that from your work and your research in terms of the issue of accessibility?
Yes, thank you so much, Steve. That's a pressing question that's been pounding on us for years, and we know that internet access, or at least bandwidth, high-speed internet access, is a very important social determinant of health, and especially for those groups from underserved population. We could not even assume they even have a device or infrastructure to access internet. So that basically cuts them out from those virtual support. And as I monitor in the chat, indeed, we can reach them through phone calls, but sometimes, their reception or signal may not even be good enough to accommodate long-time phone calls. And for our program, I would say, thanks to Dr. Anik and his team who created the program, is we provide a hybrid option, which is they can either come in person or through virtual. And Anik, are you here? I think you will be the best person to dive in depth about these thoughts.
I don't know. Can you hear me? Hello, everyone. Sorry, it's like 5 o'clock in New Zealand. So we provided also the possibility of people to access hybrid programs. So but of course that was hampered by the COVID restrictions. But in some of our programs, we were in between lockdowns and in between different situations and changing environments, but we found that a hybrid way to reach people worked very effectively. When people found one way of connecting, whether it was online or whether it was face-to-face, then they engaged rapidly in the rest of the program. So that was the lockdown, the COVID special challenge that we had. But hybrid program was the best that we could do for people who did not have either devices but when we worked with schools, we found that the schools were sharing devices, giving people data access. So that was a great that happened in Australia. So yeah, for every situation, you really have to dig down and see what is the barrier here. Is it Is it bandwidth? Is it money to access? Is it a device and deal with it effectively, as effectively as possible?
Fantastic. Thank you both for that, and also to Anne-Marie and Cindy for their response earlier. Please do, in the moments that we have left, if you have a question, please do post it or raise your hand. I'm going to exercise chairman's prerogative in the absence of being able to see any others, and just bring Maria back into this. And Maria, your piece of work is really fascinating because it's focused on staff working directly in the service. But I wondered what your experience was of whether there was any kind of resistance to people coming forward to access the service initially, and what challenges you've had in encouraging people really to take part in that. Because sometimes raising those issues in the workplace, particularly in a mental health trust, can be particularly difficult.
Yes, that's a really good point, Steve. So it is a challenge, it's an ongoing challenge. So we work with a wide range of staff working in a number of different hospitals and organisations, and also staff working in care homes. There is a lot of stigma around staff coming forward for help. That's why we try and do a lot of work with managers and leaders, because we feel they're in a very influential position to be able to actively encourage staff coming forward. And we've done events like stakeholder events where senior managers have been quite open and talked a bit about their own difficulties and their own struggles. And that's had quite a powerful effect in terms of shaping the culture and kind of making people feel it's okay to come forward. We also try and think about our sort of communication strategy and have quite a broad strategy so that we can reach staff that work in different settings. We link in with the staff networks because we feel that's a really good way to cascade information, be in touch with information, and staff who are kind of on the ground, if you like, and particularly trying to reach those harder to reach and more vulnerable staff groups. But it is an ongoing challenge and very much sort of work in progress.
Thank you, Maria. That's really, really helpful. Okay, well, I think that time has beaten us. We always could do with more time to get into more depth, but for those of you that have got up really early, you'll want to get on and have your breakfast. Those of you that's really late, you probably want to go to bed. I'm kind of caught somewhere in between. I think it just falls to me firstly to thank our presenters for not only outlining the work that you're doing, but actually doing the work itself. It's fantastic, and thank you for submitting your innovation to our publication. I remind people that the publication is now available on the NHS Confederation's Mental Health Network website. I'm sure a colleague is going to post another link in the chat before we close for that. It'll be on the IMHL website very, very soon. We're updating our website, so hopefully it'll be there for the new version. I particularly also want to thank Emma Pavley and James Maddox from the NHS Confederation Mental Health Network for helping to make this event happen and bring it together. I'd like to thank my colleague, our North American Regional Lead for IMHL, Kathy Langlois, for helping to also bring together all of this work. And it's through their efforts that we have a publication and that we've had this event today. Please do visit the Mental Health Network website, and please do also visit the IMHL website. If you care to join us as an organisation, it's free to join. Just click on imhl.com/join. It's been wonderful to have so many people from so many places here with us today. What it goes to prove is that when difficult times arise, people come up with innovation and are able to respond to those challenges. And I think in the mental health community, we're particularly adept at doing that. We want to continue to share these innovations. So I urge you to keep in touch with each other, share your knowledge and expertise so that we can all benefit. And thank you once again for joining us today for this webinar. It's been a delight to have you with us. Sean, is there anything you wanted to say in closing?
Excellent chairing, Steve. Thank you. I felt a real connection to people across the globe. So well done, everybody, for the late nights and things. Thanks very much indeed. Need to let you go now.